Yeah, how are you?
Rolling along singing a song. Happy to have you here today because you are a distinguished faculty member and you have been leading the way in regard to upstream prevention, in regard to integrative and whole person care. And I'd like you to talk about what inspires you to do what you do and to talk, if you would, about the books you've written that extend your reach and frequency.
Yeah. I do have a little bit of a slides. I think that would probably be a little bit easier
Sure.
to share. But I think before I put that on the screen, I think I just want to say a little bit about my own journey here, just how I end up where I am. So I back in medical school, I think I realized quickly that when there's a pretty significant lack of learning on how to stay healthy, what health is, and how people can live healthy, productive, long life. And I think early on, I realized I'm not going to get that in medical school. So I started even in first year of medical school, I've already ventured out. And in the third year of medical school, I spent a month working with Andrew Weil in Arizona. This is, before all of the integrative medicine became the thing, and became friends with him. And at some point, going decade forward, when I realized I'm going to go into geriatrics and I'm going to specialize in taking care of older adults, Andy asked me to join the integrative medicine board that was forming at that time. And so through that work, I connected to most of the leaders in the field. And when Andy later said, well, how about writing a book on integrative geriatrics? Because we have a whole series of different volumes of integrative medicine within Andrew Weil library. And so that's how the integrative geriatrics textbook happened. And since I've been teaching a lot of fellows and students and trying to be the voice saying, look, healthcare for older adults have to change in this country. And so with that, what I'm going to do is I'm going to share my screen and we're going to talk a little bit about some of the work I've been doing. But more importantly, what I really want to show today is, there's a couple of actual clinical sites and some clinical pearls, but the biggest thing I really want us to concentrate on the fact that we are in a crisis. We're in a horrendous crisis of wrong healthcare for older adults in this country. I hope that this crisis will be moving towards something that's a bit better. But let's start with just kind of very basic things that very patient-centered. So I'm going to show us two patients. So both patients have noticed that they're very healthy people. I want to start with that to show how miserable the current model is and how it needs to be done completely different. So some of the listeners may not resonate with one or the other person, but that's why there are two. So there are two pretty typical older men. So one is a bit older, close to 90. He's a very healthy man until even into his 80s. He's developing some minor problems. When he was younger, Rudolph really had a bad experience with healthcare system. And he said, I'm going to go to see a doctor through my dead body. And I'm going to run away from all my illnesses. So that's really his motto. When he got into his 80s, he started realizing there were multiple things that he actually does need to see a doctor. But everything that doctor will say to him will be met with a very, very high level of skepticism. He will run the sort of everything by his friends and by Mr. Google, and he would always critique pretty much anything. And then there's Lucas, who is a bit younger, who was a very successful businessman. And in his late 70s, he started getting the knee pain, which is, of course, very common, just an old person arthritis. And, if you don't know how to handle this, the default in this country, take some painkillers, right? I mean, that's what we're learning. So, and that what set Lucas for disastrous consequences, just starting to take increased amount of the pain pills, and we're going to show you what actually happened here. So when he started taking the Motrin or ibuprofen, he started developing very subtle side effects, a little bit of a heartburn, a little bit of leg swelling. He went to his doctor, and the doctor said, "Oh, you have a heartburn. Why don't you take a heartburn pill? Oh, you have a swelling. Why don't you take a swelling pill?" So this is the beginning of what we often describe as a cascade of overprescribing, which is a current default. So let's take those two cases in our back of our minds, hold them, and think about how they're going to represent the rest of this conversation, and you will hopefully understand sort of using these two cases where we are today. So how do we approach each person? That's a key message always, right? How do we target messaging to them? How do we respect their backgrounds and beliefs? And can we bring Lucas to the health he was in 70s? And can we maintain Rudolph where he's at, right? So this is our dilemma for this next time. So let's look at this. Healthcare in the United States is expensive. We all know that. I'm not going to discuss that, but it's also not very good. So look at the statistics. So in 2016, and there's a reason why this data ends in 2016, because what happens after 2016 is less interesting in a sense because it was dramatically impacted by COVID. But look at this dip. Somewhere in mid like 2013 or 14, US life expectancy started to go down. And while basically the rest of the world continuously creep up, despite some occasional blips. But look at Japan. Japan is in 2015 was at around close to mid 80s versus we were dipping under 80. We were told on many occasions that we have a epidemic of opioid abuse, that there is a lot of accidents in the country, alcohol use, etc. Believe it or not, that doesn't explain anything that's happening on this graph. It is a massive lie. It is a massive distortion of reality. And what really explains this deep is the failure of healthcare system. And I'll show you, and I'll show you the proof of it in a minute. But in essence, it's basically a very simple reality. We're at the point where the complexity and the total number of patients sick with chronic illnesses is such that the management of that chronic illnesses, which basically doesn't exist, what we have is maintaining status quo of chronic illness. We don't have any tools to reverse chronic illness. We don't have any formally implemented tools of understanding the drivers of chronic illness. We sort of just, you have this, you take this pill. That's where we are. Or in the best case scenario, if the doctor is a little bit better, it'd say, okay, you have this problem, do this exercise, or do this kind of lifestyle intervention, eat this. The reality is that is a completely wrong thought process. Even the people who would say you have diabetes, let's do lifestyle changes, that is still a wrong thought process. The thought process should not start, what do I do for something? The thought process should be, how did this patient got here? And that thought process requires us to go away from healthcare system the way it's currently practiced. It requires us to go away from diagnosis. It requires us, more importantly, to go away from the traditional thought process that we're going to work this up and we're going to give it a label and we're going to treat it with something, because we don't have a system for that level of functional thought process, right? We have a diagnosis and a treatment model, which is not what we need. So multiple conditions. Look at this, a French paradox. What you're seeing here on the right is Americans. 42% of us, as of 2014, now down numbers are even worse, have more than 3 medical problems if you're older than 60. And it's 3 times better in France, right? So you can arguably say, well, but, they're French and, their lifestyle is different. Sure, of course, it's all lifestyle. We know that. But that's what we're dealing with today, right? It's sort of irrelevant to say, okay, let's change everybody's lifestyle overnight. Like, that's just not going to happen. There's no political will. There's all kinds of systemic infrastructural challenges to this. This is what individuals have to deal with, and as a healthcare system, and I'm in it as a provider, I'm dealing with this day to day. It's sort of, expected that you're looking at this picture and you're going to say, well, how do we treat this? Well, guess what? How do we manage chronic care illness in this country? We manage this with pills and more pills. So this is pretty scary. And it's not just the fact that 90% of 65 plus Americans take at least one medication. That is, you can arguably say, okay, well, that's expected. But look at the percent of 40-year-olds and 50-year-olds. 70%, almost 70% of 50-year-olds take one pill. I mean, think of the level of burden that this generates. And, you know, if you want to look at this from numerical perspective, and by the way, 42% of 65 Americans take more than 5 medications, right? And there's 25% who take more than 10. Quarter of Americans over 65 take 10 pills a day. You know, that should automatically scare everybody, because it simply means that, you know, we're in such a level of mishandling all of this complexity if we are allowing 25% of Americans take 10 medications and think that that's okay. It's not okay. And by the way, this is how it looks in Lucas's case. You know, you started with ibuprofen, and by in a couple of months, you're on 5-6 medications. If you think that this is rare, no. Now, of course, this case is adopted. It is a real person with changed name, but the actual truth of the case is there. I see this at least a couple of times a week. When a patient comes to my practice and I would go back in time, I spend an hour with the patient and I would discuss all this, it'll become pretty obvious that there are not necessarily even errors. It's basically a complete lack of infrastructure for prescribers who were prescribing medications to Lucas before he came to me to do better. You know, they have 5-10 minutes with him. They can't ask him how this happened. They don't understand his lifestyle. They don't know him. And even if that would be a great primary care doc who knows the patient very well, typically that great primary care doc does not have other tools. Because if you want to treat edema differently, well, you have to have other tools. You can't just simply say, oh, I'm not going to prescribe. Not prescribing or deprescribing, as we would do in this case, so trying to get rid of some of his pills. You can't do that if you're not offering tools that are effective, that are not pills, right? And that's the bigger problem. The bigger problem is that, trust me, good physicians would love not to prescribe. They know this. They know that this is a big problem. They don't have tools. And this is, and an integrative geriatrics what gives us the tools. But look at this crazy statistics. 3 million serious adverse reactions a year. More than 80% of this 3 million are in people who are over 65. So it's not surprising that what this ends up being is that the drugs that we prescribe are the third killer of people in US. This is slightly dated. This is 2007, and it's dated on purpose. We knew about this for 15 plus years, that we're killing upwards of 250,000 Americans with our healthcare system, and we're still doing nothing. And what really frustrates me, most of these patients are my patients. So most of these patients are people over 65. And, you know, you're talking about opioid deaths a year. They're probably 40 to 50,000. But no one talks about everything else. No one talks about that 5 times, 6 times that amount. It's a regular healthcare as we do it. You know, it's not, this is not an errors, by the way. This is not when prescription is prescribed incorrectly. This is correctly prescribed medications for their indications without an error, and that's what they're contributing. And this is also one of the fastest growing causes of deaths. Heart disease is actually on a turn down. So heart disease, we're doing better. Cancer is flat. It's not up or down. But the drug-related deaths are increasing steadily by 5 to 10% a year, depending on how you look at the data. So this is the solution. The solution is integrative geriatrics. It's really a whole person, patient-centered, primarily non-pharmacological approach. Instead of starting Lucas with the knee pain on a pill, we would have started Lucas with physical therapy, acupuncture, herbal and supplements preparations, and probably also simple education to say, don't take the pill. You know, you could do other things, because a lot of the times people will take a pill because they don't know either. it's not just the doctor doesn't know or doesn't have access to this modalities, but also patients often don't know that they have alternatives. So we have a lot to do, right? So we have to do many more podcasts like this. So um,
Continue. I have a comment to make when you're done.
sure. No, let's take a pause here. It's a great pause because then now we're talking a little bit about more specific clinical scenarios.
When I was a young physician, the National Institute of Aging was being chartered and debated, and NIH did not want it. It said, we'll take care of any age person. We don't need a separate institute on gerontology on aging. And Florence Stevenson Mahoney, she was one of the creators of the NIH. That's how far back she went. Also, her home was used by Bill Blatty to film the Exorcist movie. Florence Mahoney did not like the person proposed to be the director of the Aging Institute because she thought they looked backwards, not forwards, and didn't understand their lack of what you said, tools, lack of education about the evidence. I don't know if you remember Bob Butler, but Bob Butler was her choice, and he became the first and a very, very powerful director of the Aging Institute. We've known this for a long time.
For a long time. This has
And
been a
your
problem for 20 plus years, if not 25 plus.
Paul Dudley White was still lecturing when I was a young acolyte. He pointed out that if they had one heart attack victim at Mass General Hospital in any given year, they would write it up. This is the 1930s. He was inventing the EKG machine at that time.
Mm-hmm.
They would write it up because heart disease was rare. And then within a generation, it becomes the biggest killer of Western civilization because not of genetic changes, because of lifestyle, packaged goods. Sitting is the new smoking, et cetera, et cetera. Now, what I'm excited about is that you don't just point to the problem. You articulate solutions, news you need, and solutions you can use today.
Exactly.
And, you know, having spent time with Andy Weil, having spent time yourself in person-centered, really preventive care, that to me is the opportunity to save lives and treasure. And we need to have a reimbursement system.
We do. And that's another thing. Like here's a funniest example. Medicare reimburses for nutrition only if you have diabetes,
Right.
end-stage renal disease,
Right.
and a couple other really like endpoint diseases from which you don't come back. So even more interesting, right? So now everybody gung-ho about continuous glucose monitoring. Guess what? They only cover it if you already have a diabetes. By that point, it's too late.
Right.
You could avoid having all this if you're carefully assessing and addressing why someone's sugar starts to run up. Yeah, we have, well, but you could go track back to the 70s and ask the question, well, Medicare was never created as a preventive model.
Oh, no, correct. It was built off of Blue Cross Blue Shield,
Yeah.
which was created by surgeons to reimburse for procedures and prescriptions, not for outcome measured, evidence-based results. Social determinants of health have been ignored for too long. Don Berwick, among others, has been a giant in articulating the opportunity for just the kind of caring and competence that you describe.
Yeah,
so we
absolutely.
do need more of this. We do want people to get the message that what you eat, drink, think, and do matters.
Yeah. No,
My
100%.
dad, my dad at 90 took no prescriptions, but he was active and joyful. And I'll just mention that when I got to NIH, one of the things that young scientists often do is they have their family measured because they know they're crazy, they just don't know why or how. So I get a memo back in the days when they issued memos. My father had such severe nutritional cirrhosis. So in his childhood, he had such poor nutrition that his liver scarred.
Hmm.
And they had a protocol, but they said there is a 0% chance that your dad will live 5 years. We did nothing that they recommended, and we had him for another 45 years.
So you see, this is the ultimate reality. The current evidence-based medicine is a lie. It
Right,
is a lie of colossal proportion. Less than 10% of what doctors do is truly evidenced.
right,
90% of what we do has nothing to do with health. It's all managing acute, subacute, and chronic problems. And the reality is there hasn't been any infrastructural support to say, how do we keep someone healthy? We're only in the business of preventing or trying to diagnose early and prevent complication of illnesses. There is no cancer prevention program in this country. It's only early detection and early treatment. That is not a prevention. The diagnosis of breast cancer early is great, but it's grossly inadequate. Diagnosis of all cancers and all chronic illnesses early and trying to modify them grossly inadequate if you don't have a model which tries to tell to the person, we can support you not getting this illness. Right now, this doesn't exist. It doesn't exist as a system. Providers, unless they specifically go into integrative or functional medicine, don't know how to do it. They're not learning this in medical school, or if they're non-physician, unless they're holistic providers. If they're naturopath, if they're acupuncturists, and I don't list everybody, we don't have time for that, then sure, then they're learning the tools. But those people are generally not very well covered by healthcare system. They don't have access into the large academic centers for most part, or if they do have access, it's very limited. So in short, the model is not there. And frankly, let me show you a couple of more slides, just one specific clinical scenario. I have three, but I'm just going to show one because that's all the time we have today.
hmm,
So I just want to show you, a lot of people end up on PPIs. The PPIs, proton pump inhibitors. So those are the anti-acid pills, right? The moment you have a little bit of an acid reflux, you go to your doctor. They may be going to tell you to cut out coffee and chocolate. Often that conversation takes 30 seconds. And then they said, oh, and by the way, if that doesn't work, take this pill. And, there's no emphasis on actually not even talking about the pill and just really going with trying not to get to the point of a pill. The pill goes on. The problem is that what we know that once that pill is on, a lot of times it doesn't come off. And it takes often years before somebody's going to question, well, why is this person still taking, anti-acid, even though they have never complained in the last several years on anything acidity based? Well, the problem is that these pills may be very safe in the short run. In the long run, they're horrendous. I'm not even telling you that they're also now being tapped to be a possible cause of Alzheimer's disease. So, these pills have lots of problems. They definitely shorten life. But nobody wants to acknowledge that this effect is actually, on a grand scheme, is dramatic, because the problem is individual may be at the low risk for particular things, but we have millions of people taking these pills. So the amount of actual consequences from these pills is pretty large. So what can we do? Well, let's give it back to our followers. Let's give it back to individuals. Well, you actually can do a lot. You can instead take aloe, okra, DGL, D-glycosidated licorice, and you can slowly taper the PPIs down. One thing you cannot do, you cannot abruptly stop them. If you abruptly stop them, there's going to be a surge of acidity in your stomach, and you're going to feel a lot worse for a while. So what you want to do, you want to gradually taper it down. You could substitute for different pills. So famotidine or Pepcid would be a decent substitution because it's not as dangerous, it's not as effective. but it may work while you're also adding these natural products. You slowing your chewing, you eating more mindfully. You're allowing your system to be more parasympathetic when you eat, so more rest and digest rather than eating on a go during stressful meeting or eating right after somebody yelled at you, or even the worst, people eat in the car while driving. That's like the ultimate crazy. So, you really take your time, you allow digestion to its due course, its due time, you give it support, and you can use all these herbs. And, in essence, when you do it this way, chances of coming off is very high. And it's one. Now I have multiple other pearls like this where people can get off of other things, like the next one, which I think we're going to stop here. But the next one is really all about sleeping pills, which is a whole lot of separate conversation for 10-15 minutes. So I'm going to stop at this. I think we've covered this a little bit. It's always wonderful to be with you, Dr. Jaffe,
And with
and
you.
Kirk.
So we're speeding the transition from symptom reactive care to true primary personalized prevention.
Exactly.
May you be well and happy, and may you thrive in the 21st century despite the systemic needs that we have to change and improve the human capacity to evoke healing responses.
Exactly.
Thank you so much for being you and for what you do on behalf of so many. So thank you.
Thank you so much.